You know, usually when we talk about a medical diagnosis, there's this expectation of clinical precision.
Right, yeah, it's very black and white.
Exactly. Like you break your arm, the x-ray shows that jagged white line, and the doctor just points and says, there it is. Broken or not broken, it's clean.
Yeah, the protocol is obvious.
Right. But then you consider a scenario that countless people face, yet we almost never talk about it openly. I mean, imagine staring down a routine, highly necessary medical procedure, a speculum exam, but your body's natural tissues have been fundamentally compromised.
Oh, absolutely. It's a huge issue.
We are talking about tissue altered by the natural progression of menopause or, even more severely, by life-saving cancer treatments. Suddenly, that routine exam isn't just uncomfortable, it is a source of profound dread.
It really becomes this massive physical and psychological barrier. And I mean, that is the core of our focus for this deep dive.
Yeah.
Because this isn't merely a conversation about temporary physical comfort, We are looking at the fundamental accessibility of life-saving interventions.
Definitely.
Because if a cervical screening or a post-cancer follow-up exam is just too painful to endure, patients will simply delay or avoid those screenings entirely.
Which is terrifying when you think about what's at stake for you, the listener. So our mission today is to dig into a stack of clinical guidelines, NHS leaflets, oncology research papers, and practice-changing studies.
We've got a lot of ground to cover.
We really do. We want to extract the most vital insights to answer one critical question. What non-hormonal barrier protectants are recommended to shield fragile, dry mucosa before an oncologist or clinician performs a routine speculum exam?
And, that non-hormonal aspect of the question is particularly crucial, especially when we look at the specific, very complex needs of cancer survivors.
Right. Okay, let's unpack this. I want to start with the biology because I always assumed I understood what estrogen does. I mean, I thought of it primarily as the hormone that just controls the reproductive cycle.
A lot of people think that, yeah.
But looking at the sources, it suggests it's doing something much more structural to the vaginal tissue itself. So what is actually happening at a microscopic level when those hormone levels drop?
Well, estrogen is heavily responsible for the physical architecture of the vulvovaginal epithelium. That's the skin lining the vagina and vulva.
Okay.
So when a patient enters menopause and estrogen levels drop, it triggers this condition known clinically as genitourinary syndrome of menopause, or GSM.
Right, GSM.
Exactly. The tissue loses collagen and elastin. And those are the proteins that, give the skin its stretch and its bounce.
So it just loses all its elasticity.
Yeah, completely. And without them, the epithelial cells literally lose their ability to hold water. I mean, think of a plump grape slowly losing its internal pressure and just drying into a raisin. The skin itself becomes incredibly thin.
Wow, so it's losing that internal water pressure. And what about the microbiome? Because I saw some fascinating notes about how the bacteria actually change during this process, too.
Oh, that is a brilliant piece of the puzzle. So a healthy, thick epithelium, supported by estrogen, constantly sheds surface cells.
Okay.
And when those cells shed, they release a type of sugar called glycogen. The protective, good bacteria in the vagina, the lactobacilli, they feast on that glycogen.
Oh, they eat the sugar.
Right. And as a byproduct of digesting that sugar, they produce lactic acid.
Which keeps the environment acidic, I'm guessing?
Precisely. It keeps it down to a pH usually between 3.8 and 4.5. And that acidic environment acts as this invisible shield against infection.
That's amazing.
It is. But when estrogen disappears, the skin thins out and the cell shedding stops. So the glycogen disappears, which means the lactobacilli starve.
Oh, no.
Yeah. And the pH shoots up, creating an environment that is completely vulnerable to pathogenic bacteria and severe inflammation.
I mean, that paints a tough picture just for natural menopause. But the guidelines emphasize that for cancer survivors, this biological cascade goes from bad to absolutely devastating.
It does. Because when we factor in oncology treatments, we're looking at trauma layered on top of deprivation.
Right.
If a patient undergoes pelvic radiotherapy, for instance, the radiation doesn't just reduce estrogen, it directly damages the cellular structure.
Structurally ruins it.
Exactly. This often leads to vaginal stenosis, which is an actual physical narrowing and shortening of the vaginal canal, accompanied by a severe loss of elasticity.
And then there are the systemic drugs, right? Like the ones used for breast cancer.
Yeah, for patients with hormone receptor-positive breast cancer, oncologists frequently prescribe aromatase inhibitors. So drugs like anastrozole or letrozole.
Okay.
The entire purpose of these medications is to ruthlessly eliminate estrogen from the body, to starve the cancer cells. But as a side effect, they plunge the vaginal mucosa into a state of severe, unprecedented drought.
Man. So if I'm picturing this right, a healthy vaginal mucosa is like a thick, well-hydrated sponge that can easily stretch and bounce back.
That's a great way to put it, yeah.
But after estrogen deprivation or radiation, it becomes like dry, cracked desert earth. So if a standard metal or plastic speculum hits that compromised tissue, it doesn't have the internal water pressure or the structural stretch to accommodate the instrument.
No, not at all.
It just tears. The sources detail how this causes fissuring, which are actual microscopic tears in the tissue, and petechiae, which are these tiny, painful microbleeds right under the surface.
Exactly. So the patient isn't just feeling pressure during the exam, they're experiencing active acute tissue trauma. I mean, the pain can be agonizing.
And, whether you are prepping for your own upcoming exam or you are supporting a partner navigating post-cancer care,
Yeah.
understanding this mechanism of the cracked earth is the very first step.
Absolutely.
Because you can't advocate for better care if you don't know the physics of what you're trying to protect. So moving on to the solutions, how do we rebuild that shield? And why are the guidelines so aggressively focused on doing it without hormones? I mean, if the problem is a lack of estrogen, shouldn't a doctor just prescribe an estrogen cream?
Well, while local vaginal estrogen is generally considered the gold standard treatment for general GSM, it becomes a major risk factor for many breast cancer survivors.
Ah, because of the cancer cells.
Right. Specifically, those on the aromatase inhibitors we just mentioned, they are strongly advised against using it, because even the tiny amount of estrogen absorbed systemically from a local vaginal cream could potentially stimulate dormant breast cancer cells.
Okay, that makes sense. The oncology team is trying to keep estrogen at absolute zero, so introducing even a single drop is totally counterproductive.
Exactly. Which makes non-hormonal barrier protectants the absolute safest first-line defense.
Okay.
And according to the guidelines, the preparation for a speculum exam doesn't just start in the waiting room. It starts weeks in advance.
Right, they break it down into two categories, emollients and moisturizers.
Yeah, because rebuilding tissue architecture takes time. Let's look at the emollients first. The very first rule the clinical sources emphasize is about rethinking basic hygiene. Patients are advised to completely stop using soap.
Really? Stop using soap entirely?
Yes. Soaps, bubble baths, even the products marketed as, sensitive feminine washes, they strip away the minimal moisture that is left and just irritate the already vulnerable tissue.
So what are they supposed to wash with instead? Water?
No, medical moisturizing washes. The NHS leaflets specifically mention products like QV Gentle Wash, Hydroalol, or Cetraban.
Oh, I've seen those.
Yeah, they clean the area while actually leaving a protective emollient film behind. And furthermore, in conditions that cause severe external thinning and scarring like lichen sclerosis, the guidelines recommend using yellow soft paraffin.
Wait, yellow soft paraffin, that's essentially Vaseline, right?
It is, yeah. They recommend using it externally as a heavy barrier cream, specifically to protect that damaged vulvar skin from the acidity of urine.
Wow, okay. So emollients handle the external washing and the immediate physical barrier. But to rehabilitate the internal tissue, that dry, inelastic environment, we need vaginal moisturizers. And the sources are very clear that these are totally different from the standard lubricants you might buy for intimacy.
Oh, completely different. Lubricants are designed to be temporary. They just sit on the surface to reduce friction in the moment.
Right.
But moisturizers are engineered for cellular rehabilitation. The guidelines highlight products that utilize bioadhesive polymers like Replins, or hyaluronic acid like Hyalofem or YesSVM.
Now, hyaluronic acid is everywhere in skincare marketing. I mean, you see it on every face cream. But what is it actually doing inside the vaginal canal?
Well, it acts like a microscopic water magnet.
Hmm.
When a patient applies these moisturizers internally, the molecules physically attach to the epithelial cells on the vaginal wall.
Oh, wow.
Yeah, they hold on to water, mimicking the natural secretions that estrogen used to provide. And by using them regularly, typically every 1 to 3 days, often applied at night, the tissue slowly rebuilds its plumpness and elasticity over several weeks.
But the science of formulation here seems incredibly strict. I mean, the sources warn that you can't just grab whatever random tube is on the drugstore shelf.
No, you really can't. The chemical makeup of the product is vital. An ideal vaginal moisturizer must match that natural vaginal pH, the 3.8 to 4.5 range, to help suppress pathogenic bacteria.
Okay, that tracks with what we talked about earlier.
Right. But it also has to match the natural osmolality, which should fall between 260 and 290 milliosmoles per kilogram.
Okay, you completely lost me there. What on earth is osmolality and why does a moisturizer care about it?
It's a big word, but it basically refers to the concentration of dissolved particles, like sugars, salts, or glycerin within the gel.
Okay.
If a product is hyperosmolar, it means it has a much higher concentration of particles than the human cells it's touching. And nature always seeks balance, right?
Yeah.
So a hyperosmolar gel will actually suck water out of the vaginal tissue through osmosis, just trying to dilute itself.
Wait. So a product you specifically bought to moisturize that fragile tissue could actively dehydrate it.
Exactly. It pulls the last bits of internal water right out of the cells, causing further cellular damage and stinging.
That is why.
Yeah, that is why patients must seek out isoosmolar products, which have the exact same particle concentration as the body's own cells, allowing the moisture to actually absorb properly.
You think you're helping, but you could actually be doing more damage if you grab the wrong one. Okay, so let's say a patient finds the right isoosmolar pH-balanced product. They spend weeks meticulously hydrating this tissue. If these moisturizers are the ultimate shield, shouldn't a patient apply a really thick layer right before they walk into the oncologist's office for the exam?
See, what's fascinating here is if they do that, they will completely ruin the test.
Wait, really?
Yes, the clinical guidelines are inflexible about what they call the 2-day rule. Patients must completely stop using all moisturizers, barrier creams, and vaginal medications 2 full days prior to a cervical screening.
But why? I mean, I just spent weeks rehabilitating this tissue. Why would I leave it completely defenseless for 48 hours right when a rigid metal instrument is about to be introduced?
Because of the microscopic mechanics of the screening itself. During a smear test, the clinician uses a tiny soft brush to collect cells from the cervix. If the vaginal canal is coated in a bioadhesive polymer or a thick layer of hyaluronic acid, the brush just picks up the polymer residue.
Oh, I see where this is going.
Yeah, when that sample goes to the lab, the residue completely obscures the cytology, which are the actual human cells they are trying to examine to detect cancer.
So the lab will just reject it.
They will mark the sample as inadequate. And the tragedy is the patient will be called back and forced to endure that painful exam all over again.
Ugh, that sounds absolutely terrifying. So the patient has to intentionally fast from their protective moisturizers, meaning when they finally step into the exam room, their tissue is incredibly vulnerable once again.
Exactly.
So how do we protect them at the exact moment of insertion without contaminating the lab sample?
Well, here's where it gets really interesting. Because we run into a massive historical hurdle in the medical community. For decades, there was this deeply ingrained clinical dogma, a rigid rule taught in medical schools, that you absolutely could not use any lubricant on a speculum during a pap smear or an STI test.
Why were doctors so terrified of a little lubricant?
Well, historically, before the invention of modern liquid-based cytology, clinicians would literally smear the collected cells directly onto a glass slide.
Oh, right.
And the fear was that any gel introduced into the environment would create a blurry smear under the microscope, or that the chemicals in the lube would interfere with the chemical tests used for detecting things like chlamydia.
So what did they use?
Generations of clinicians were taught to only use warm water to lubricate the speculum.
But if we think back to that tissue, the raisin-like inelastic cells lacking internal moisture warm water provides absolutely zero glide. It just evaporates.
It is essentially doing nothing. And despite the transition to much more advanced liquid-based testing, that fear of lubricant lingered in clinics everywhere. It took rigorous scientific evidence to finally dismantle that dogma.
The 2012 study, right?
Yes. The sources highlight a practice-changing randomized controlled trial from 2012 by researchers Hill and Lambu.
I love the methodology of the study because they didn't just, slather the instrument in gel. They were incredibly precise.
They really were. Hill and Lambu designed a trial with 120 women to test 2 things. Would a tiny amount of water-based lubricating gel ruin modern tests? And would it meaningfully reduce the patient's pain?
Okay.
They applied just 0.3 milliliters of water-based gel exclusively to the outside of the speculum blades.
0.3 milliliters. I mean, that is barely a single drop.
But the statistical results were profound. First, they proved definitively that this microscopic amount of gel did not interfere with the liquid-based cytology, and it did not obscure the chlamydia detection.
So the test came back perfectly readable.
Exactly. The dogma was officially outdated.
And what happened to the patient experience in the room?
The overall pain scores dropped significantly, but the most striking statistic to emerge was that 33.9% of the women in the gel group reported a pain score of absolute 0.
Zero pain.
No pain at all. Compare that to the water-only group. where only 10% reported zero pain.
That is incredible. Applying less than half a milliliter of gel more than tripled the number of women who felt zero pain during an inherently invasive procedure. It's like putting a tiny drop of oil on a tight, rusted door hinge.
I love that analogy.
Right. It's just enough to stop the agonizing metal-on-metal friction as the door opens. But you aren't, like, flooding the room and ruining the microscopic evidence the doctor is looking for on the floor.
Exactly. And crucially, it gives the clinician exactly what they need while protecting the patient's vulnerable tissue.
But the gel is just one part of the physical adjustment in the room. The sources outline several other crucial tools and techniques that can be employed because the standard equipment is often just not appropriate for atrophic tissue.
No, it's really not. Patients have the right to request a narrower speculum, like a Patterson speculum, which has much slimmer blades.
Or even a pediatric speculum for severe cases of vaginal stenosis following radiotherapy.
Right. The patient can also ask to insert the speculum themselves.
Oh, that makes so much sense.
It does. Allowing the patient to control the angle and the speed of insertion radically reduces both the psychological anxiety and the physical tearing.
There is also some fascinating innovation finally happening in the design of the speculum itself. I mean, the traditional duckbill speculum, which has those two blades that hinge open like a beak, it focuses all the mechanical pressure onto just 2 points.
Which is intensely painful on tissue that can't stretch.
Yeah, but the sources highlight a newer device called the bouquet speculum. It has 5 petals instead of 2 blades, and it opens radially, expanding like a flower.
Which distributes the physical force symmetrically and evenly across the vaginal walls. It completely changes the physics of the exam.
So what does this all mean for the patient? That tiny drop of gel, combined with weeks of rehabilitating the tissue and using the right equipment, it completely changes the landscape of a routine screening. But for patients recovering from cancer, specifically pelvic radiation, the protective strategies go even further, don't they?
They have to. We discussed earlier how pelvic radiotherapy can cause vaginal stenosis, where the walls can permanently fuse or narrow.
Right.
For those patients, barrier protectants are integrated into vaginal dilator therapy. Oncology teams prescribe the use of medical dilators 3 to 4 times a week to physically maintain the capacity of the vaginal canal.
And what role does the lubricant play there?
It is absolutely critical for preventing trauma during the therapy. Patients must use a high-quality, water-based lubricant, like the ESWB mentioned in the guidelines, to protect the mucosa while using the dilators.
The type of lube keeps coming up. Why is it non-negotiable that it must be water-based?
Well, earlier we mentioned that patients might use Vaseline or oil-based emollients externally for washing and barrier protection.
Yeah, the yellow soft paraffin.
Exactly. But you cannot use oil-based products internally during a clinical exam or with medical devices. Because in cases where a patient has a prolapsed vaginal wall, the clinician sometimes has to place a latex condom or sheath over the speculum to safely hold the tissue back so they can see the cervix.
Oh, and oil-based lubricants instantly degrade latex.
They destroy it almost immediately. So water-based formulations are the only safe, universally applicable clinical choice.
Which brings us to the ultimate takeaway for you, the listener. I mean, you are the primary advocate for your own body. If you are going in for a screening, you are allowed to pause the exam.
Absolutely.
You are allowed to ask for the smaller pediatric speculum. And if you are afraid the clinic won't provide a clinically approved isoosmolar water-based lubricant, buy one yourself. Bring it in your purse. Hand it to the clinician and ask them to use 0.3 milliliters on the outside of the blades. You have that power.
It is entirely about shifting the dynamic. You are moving from merely enduring a painful procedure to actively participating in your own safe, evidence-based care.
Exactly. So to briefly recap our journey today, we've traced the biological breakdown of the mucosa into that cracked earth state, the weeks of rebuilding it using pH-balanced moisturizers and emollients, the crucial 2-day pause, and the clinical evidence that finally dismantles that no-lube dogma with just 0.3 milliliters of water-based gel.
It is a totally comprehensive game plan for protecting yourself or a loved one. But, if we connect this to the bigger picture, looking at all these sources together, there is a deeply frustrating paradox hidden in the regulatory details.
Yeah, it's pretty unbelievable.
It is profound when you consider the stakes, because the FDA currently categorizes these vital, non-hormonal vaginal moisturizers and lubricants as
Cosmetics. So legally, they are in the exact same category as a tube of lipstick or mascara.
Under the current classification, yes. Now think about everything we've just discussed today. These specific formulations are medically necessary to prevent severe tissue damage.
Right.
They are required to manage the agonizing side effects of life-saving oncology treatments. And they literally enable patients to physically endure crucial cancer screenings.
Because without them, patients actively avoid the smear tests that could save their lives.
Exactly. So what does it say about our healthcare system? That products fundamentally tied to surviving cancer and enduring medical procedures are legally classified and therefore frequently dismissed by insurers and policymakers as optional beauty products.
It makes you wonder how much excruciating pain is just quietly accepted by patients every single day, simply because the solutions are trivialized by the system. If these products were treated as essential medical care rather than cosmetic afterthoughts, how many more people would seek out the protection they desperately need? It's something to really mull over. It's time we stop expecting patients to just endure the trauma and start demanding the tools to heal it. Until next time, keep digging deep.